Hi, everyone. This is Cameron again for the last of our three-part summary of healthcare in America. So we've already covered the history of healthcare and kind of a current evaluation. And so now we're going to talk about some potential solutions or trends or things that are just being developed and done to solve some of the problems we talked about in part two. Just to go over the history again, we started as an out-of-pocket system and then moved towards employer-based private insurance after the Great Depression and World War II. And then being employer-based left out retired people and the unemployed and the poor. And so the government took care of that with Medicaid and Medicare. And then the ACA came to try to adjust pretty much everything. And so we've talked about that in the history and in the current evaluation. And then we'll also talk about the ACA again as one of these things that have tried to solve some of those problems. So this is the quote that I chose to kind of summarize part one. It's that healthcare financing in the US evolved to its current state through a series of social interventions. Each intervention solved a problem, but in turn created its own problems requiring further intervention. So we reflected a little bit on some of the political and ethical and financial tensions from those social interventions and the problems they caused, and then also the problems that they solved. And then in part two, we evaluated the current state of our healthcare, and the overarching quote I gave was also from the textbook. It's a paradox of excess and deprivation. So there's a lot of good and a lot of not so good, basically. And so we evaluated based on quality, cost, and access. So under the quality section, we talked about the tension between variety and standardization. We also, I explained the cliff analogy to show that America is a little bit more of a sickness intervention than a health promotion system. And we talked about the lower health outcomes of Americans compared to other developed countries with universal medical coverage. And then in the cost section, we talked about how Americans spend almost double as a whole on healthcare compared to those same countries that we compared to the lower health outcomes. So we're paying double and getting less, unfortunately. We talked about some of the reasons for the expensiveness. We gave a lot of reasons, including the cost of becoming a provider, advanced technology and research, potentially wasteful expenditures, and then also just the role that insurance plays in inflating costs. And we'll kind of see that again today. And then, yes, we talked about commercial and government insurance, just kind of as an overview. I gave some vocabulary and then also just broke down Medicare and Medicaid into the simplest terms possible. They're really a lot more complicated than I could cover. And then we talked about, so cost is a financial barrier to access. We also talked about some geographic and social and legal barriers as well. So in this presentation, we're going to talk about the ACA. We're going to talk about Trump's or the conservative healthcare plan. And then we're going to talk about public health, direct primary care, and indigent clinics and NGOs. So, and it's going to kind of tie in everything that we talked about in parts 1 and 2. So, summary of the Affordable Care Act. It attempted universal coverage. It used mostly community rating. It kind of made insurance companies use community rating with the exception of age, place of residence, smoking, and size of the family. So these were the only experiential factors that insurance companies could use to raise and lower the prices. So we talked before about the tension between community and experience rating, which one is fair, what experience rating factors would be fair and which ones are not for people who are already predisposed to having more health complications. So these were the 4 things that the ACA allowed for experiential rating. And then it also produced minimum standards for healthcare plans. Basically, these mostly included testing, but not a lot of treatment. So they'll cover a few tests, but they won't cover the treatment necessary if those tests were to find something wrong. And so it also provided the individual mandate, basically said everyone has to buy into the healthcare.gov system. And if they don't, they have to pay about like $1,000 or something like that. And then it offered government subsidies, or basically tax credits, for anyone who made within 133 to 400% of the federal poverty line. And then because of that, it increased taxes on the rich, and required employee insurance. We'll talk more about the federal poverty line, I think, in the next slide. So it required employee insurance. So basically, if you have a company that has a certain amount of full-time employees, you have to buy them health insurance as a benefit. So this basically incentivized small businesses to stay small and big businesses to hire part-time workers, which was an interesting consequence. So more about the universal medical coverage and the percentage of the federal poverty line. So basically what I have listed here are percentages of the federal poverty line, 0% to 133% to 400% to infinity. So by attempting to expand Medicaid, basically the ACA wanted all states to allow people within 0 and 133% of the federal poverty line to be able to be enrolled in Medicaid. And we'll talk a little bit about why some states did not like that. And then the ACA provided tax cuts for everyone between 133% and 400%. And then it was assumed that at 400%, you should be able to afford health coverage without any government help, basically. So this was the attempted universal medical coverage. This would make healthcare theoretically affordable for everybody. The problem was states had different fiscal priorities. And so 14 out of the 50 states have chosen not to expand Medicaid. Texas is one of them. And so basically there's going to be a gap right about here. And it varies. Some states will, bring it up to 125 or 100, however they see fit for that. So it hasn't quite worked out for universal medical coverage. Also, there's the people in this 133 to 400% range who still feel like they cannot afford healthcare coverage even with these tax cuts. So that's also a factor. And then there's some people who just don't want to buy it. So there were some ethical issues with the ACA that were contested between the right and the left. What do we do with illegal immigrants? Whether the federal bureaucracy is efficient enough to handle such a system, because this is a big system. And the government's not really necessarily known for being super efficient. So can they handle this? And for a little bit, they were having a lot of trouble. So it wasn't a completely unrealistic criticism. And then whether the federal government can make more rational medical finance decisions than the private sector. So is the government really going to do a better job than the private sector? And then for whether healthcare is a right. Unfortunately, that was part of the conversation as well. And then intergenerational injustice. So basically, are young, healthy people going to pay a whole lot more for older people to have this healthcare stuff, and then they're never really going to get the payoff? So benefits and disbenefits between the elderly and young workers. Now, I have to say that pretty much any plan that's proposed is going to have most of these criticisms. So none of these were entirely unique to the ACA, but they did spur on the discussion of whether or not it was a good idea. And then the consequences. So some of the financial consequences included that 3.9 million people were willing to pay the $1,000 penalty because insurance was still unaffordable. So these are people who, they'd rather lose $1,000 than pay into the system. But these are also the people who don't want to pay into the system because they can't afford the system. So making a financial penalty for people who cannot afford something is kind of counterintuitive. And so this disproportionately hurt the poor and made several people upset. It also raised taxes, mostly on people who make more than $200,000. So an extra $1 trillion in taxes. It incentivized small businesses to stay small and larger businesses to hire more part-time staff. So basically, if you're a small business and you have 15 full-time employees, I don't know where the line is now. it might be at 50, it might be at 15. I've heard a couple different numbers, but basically once you hit a certain amount of full-time employees, you have to pay for benefits. And that's really hard for a small business. If you're just starting and you don't have a lot of revenue, you can't really put all your chips in on part-time workers. You need some dedicated full-time staff, and that becomes really expensive. So that was also a tension with small business. And then it may have slowed the increase in proportion of health expenditures, but as far as a cost containment or cost reduction strategy, there's not really a lot of evidence to support the ACA having reduced the cost of healthcare expenditures. So remember, we pay twice as much as other developed countries on average for our healthcare system. And so we need something that not only slows the increase in that, but completely reverses it. And the ACA was not the case, but if it slowed, that's at least a step in the right direction. And then you can see my source here is a conservative economic video. So it gave good information, but there's going to be bias in a lot of the information you find. So on the other hand, one of the good consequences was that it succeeded in reducing the uninsured population by about 50%. So that's pretty crazy and very impressive. And so as much as everybody, the right and the left, have problems with the ACA, we do need to recognize that it did a good job of increasing the uninsured population, even if it didn't provide universal medical coverage. And that's from the textbook. So Trump's healthcare plan, you could call this Trump's, you could call it the Republican or the conservative healthcare plan. It's a little bit harder to describe than the ACA because it wasn't as well put together and developed as the ACA got the opportunity to be. So Trump and the former Republican majority in the House and Senate aimed to basically repeal the ACA, which would have included allowing states to make their own requirements for Medicaid, allowing insurance companies to reject applicants with pre-existing conditions, so basically reintroducing experiential rating, and then also set rates for elderly up to 5 times the rate of younger people. So that age factor under the ACA, it was only 3 times the amount of younger people. Before the ACA, it was 5 times the rate of younger people, and so they wanted to bring it back up to 5 times. And that's just an acknowledgement that older people are going to cost more. They're going to use more healthcare services than younger people. So where you draw that line is kind of hard to figure out. And then it would allow employers to not offer medical coverage, which basically means individuals would have to get their own medical coverage if they worked for a business that didn't provide medical coverage. And then it would allow states to create plans not covering treatment for mental illness or addiction. So keyword here that I want to point out is allow. Most of these things look like they're backtracking progress that was made. And many people do view it as exactly that. They view it as backtracking. They don't view it as progress. But from a conservative or libertarian point of view, the word allow entails freedom and responsibility. So giving states, giving businesses, giving individuals freedom to make their own decisions and figure out what's an ethical option to them. So it didn't force any companies to increase their rates for up to 5 times the amount for elderly people. But at the same time, if that's legal, then a lot of companies will probably choose to do that. So it's a tension between, if we give people freedom, are they going to choose to be responsible with it? And that's been a tension in America for a long time. So also, if we give all of these freedoms and allow all of this to happen, can individuals really take care of themselves? That's a big assumption. And unfortunately, when it comes to healthcare, a lot of people can't, especially when we start talking about that pre-existing conditions thing. So those are some of the tensions to keep in mind with this. More specifically, actually, I'll go back. I just want to point out, this is a citation, not a political affiliation. There's a guy with the last name Pence who wrote an article in 2020. He was not the vice president. So just want to point that out. Trump's healthcare plan wanted to promote small businesses. So that was one of the bigger things he tried to do. So it allowed small businesses to unite for big business discounts on employee insurance. So basically, if you've got this huge corporate company with 100,000 employees, they're probably going to get a discount when they make a contract with like Cigna or Aetna or something like that. Whereas all these small businesses are not really, it's not really in interest of any of those insurance companies to give them any kind of discount. And so to promote small business, he wanted to allow these businesses to unite. So, you got 100 small businesses that now have 150,000 employees. That would be, I don't know if the math works out to make those small businesses, but that paints the picture of what's going on here. So that would be pretty cool. Promoting HRAs, basically this would be like an HSA, a health savings account, but for your employer. So your employer would put money into a non-taxed account for you to be able to use that money to buy your own health insurance rather than choosing a plan for you. And maybe that's the plan that worked best for your employer, but not what was best for your family. So this would give a little bit more freedom for people to spend money in the way that they think would benefit their personal selves and families as far as healthcare is concerned. So I think those are pretty good ideas that we need to give some credit to. But ultimately, the result was no drastic changes. So as much as they wanted to repeal the ACA, they didn't really provide a strong alternative to the ACA. So if they were successful, lots of people would have lost insurance and not been really given an opportunity to gain it. So now let's talk about public health. I know we're going through these super quickly, so there's a lot of information that I'm not giving, but I hope it spurs some ideas in yourself. So this is a picture of me about to swab some patients for COVID, flu, and strep. Sorry. So I thought that kind of went with public health in some ways. So a global comparison. So remember that quality section from part 2. It covered infant mortality, life expectancy, and mortality amenable to healthcare. And it compared America to Germany, Japan, the UK, Canada, and I think like one other country. So if you remember correctly, America had the worst numbers on all of those. So that's the graph the table that I'm referring to. So are those health outcomes proportional to the financial input? Remember, we pay twice as much as other countries for our healthcare. So we're paying twice as much, and then we've got the worst health outcomes. So just to put that into perspective, as far as public health is concerned, about 97% of national health expenditures in America are spent on insurance and out-of-pocket expenses, not on public health. So very little is spent on public health. Lots is spent on insurance and out-of-pocket expenses, but are insurance and out-of-pocket expenses the only two factors that really contribute to the population's health outcomes? I would argue not. So if you want to take some time to think, health determinants are basically the factors that contribute to a population's health. So go ahead and take about 30 to 40 seconds to write down all of the health determinants you can think of. I'll take care of them, just 2. There's physical activity and body weight composition. So those are some examples. Fill out as many as you can think of. Try to get at least 5. I'll give you a couple seconds to do that. All right, so I hope you got a few more down. I'll continue my list. So I also included substance use, sexual behavior, personal hygiene, diet and access to clean water, mental health, genetics, environmental hygiene, rates of injury and violence, immunizations, and access to healthcare. And actually, that's not my list. This came from a textbook. So question, how many of these determinants does your insurance and out-of-pocket payments pay for? So if we're 97% of our health expenditures are in insurance and out-of-pocket expenditures, then how much are we really getting from those 97%? That 97%. So some insurance companies will pay for contraceptives and maybe mental health. They might pay for genetic testing, but they can't really pay for genetics. And then they mostly cover immunizations and maybe will indirectly influence your access to healthcare. But the main thing here is immunizations. Almost everything else on the list is more of a public health or societal, like rates of injury and violence. That's the justice system. That's not even health, but it is a health determinant. So what contributes to life expectancy, for example, is a lot more than just what your insurance and out-of-pocket payments cover. So I think that's important to remember that we've got this. We spend a lot on healthcare. Most of that payment is through insurance, but a lot of how we measure the success of a healthcare system is not really related to insurance at all. So most of what we pay for goes to the bottom of the cliff in our cliff analogy, whereas public health is focused more on the top of the cliff, stopping things before people fall off. So we only pay about 1 to 3% of all of our national health expenditures on public health. However, how that's not really reflective of how powerful public health can be. So it's estimated that 25 of the 30 years of increased life expectancy in the 20th century was due to public health initiative. So that's 25 years increase because public health improved, and only a 5-year increase because medicine improved. If that goes to paint the picture, there's another more contemporary example. And I couldn't get into all the statistics that were used to come up with these numbers. That's not my expertise, but they do at least show an illustration if they're not perfect numbers. So cure for cancer, let's say we cure cancer right now. Life expectancy would increase about 3 years. So if life expectancy is 76 right now in America, we could expect it to move up to 79. Cure for heart disease, if we cured all heart disease, life expectancy would increase 10 to 15 years. So now that 76-year-old person is living 86 or 91 years instead of 76. So, and you can probably think of a couple people who maybe have heart problems or some other non-communicable disease that kept them from living into their 80s and 90s. And then you can probably think of people who didn't have as many of those problems who did live into their 80s and 90s. And so heart disease is to an extent a little bit more of a public health issue than it is a medicine issue. Medicine will cover what happens at the bottom of the cliff. But a lot of public health tries to catch the people before they fall into any heart disease at all. So public health as a solution in general, what I'm saying is basically that maybe we could increase some expenditure in public health and see some increase that would increase in health outcomes that would decrease the cost of all of our other health expenditures. Maybe not, but I think it's interesting to see how powerful public health can be. Another thing is called direct primary care. So basically this is primary care providers who don't take insurance. So basically, instead of taking insurance, you subscribe to that provider and you have consistent access to them through appointments or through telemed, even texting or email. It's different per provider, but basically the results of not taking insurance mean you have a lot more access. For some of these doctors, it might be 24/7. For some of them, it might be probably a little bit more limited, but definitely more accessible than your average doctor. And that's going to lead to better preventative care. If you've already paid a set amount for a month, you're going to use as much care as you need to make the most of that set amount. So, whereas before, it's going to cost you $50 to go to the doctor. So you're not going to get this random thing checked out. That random thing might turn into something worse later on. Who knows? So this does have the advantage of promoting better preventative care, especially since this is a primary care physician. And then they also get more time with their patients. So basically these physicians will spend about, they usually cut off how many patients they will accept at about 500 or 600, whereas the average primary care physician is seeing over 1,000 patients in their practice. So that means they get to spend all of their time contributing to the health of these 500 or 600 patients instead of being stretched so thin that they don't help as many people as in depth. And then there's less staffing needs because you're not taking insurance. So there's just inevitably less paperwork. So that's also a financial advantage. And then contracted lab prices. So we talked about before in part 2, how depending on your insurance company and which state you live in, your cost of a complete blood count could be $11 or it could be over $1,000. So let's see what a CBC, complete blood count, would be with direct primary care. So under a traditional practice, they're saying it would cost about $35. I guess in some places it could cost up to $1,000, whereas for them, it's contracted. So they've made a deal with a lab in their community to say, you know, we'll send our patients to you and we want them to only have to pay $3.75 for that complete blood count. So that's lower than even the $11 range. And you'll look for all of these labs, these are about 90% off basically compared to a traditional practice. And then all of this office visit copay, well woman exam, annual labs, all of that's included with membership. And then down here, you see x-rays, CT scans, MRIs are costing up to, you know, $3,500, whereas they've contracted them to get about $600 or $375. So it's still expensive for people who can't afford healthcare, but for kind of the average person economically, these are very affordable rates that are more reflective of market prices. So what is this monthly payment that they have to make? There's a $150 enrollment fee, and this is based off actually a local direct primary care clinic in town in Abilene. So $150 enrollment fee, $99 per individual per month, and then that's discounted at $85 per employee per month if you do it through your company. So versus average price of insurance is about $500 per person per month. So the problem that you might be seeing here is, well, if you have to get an MRI and that's, you know, $600 is going to be expensive. It's not something you wanted to have to pay for. Maybe it's not something you really budgeted for. But under this plan, you're paying $100 per month. And then now you've got to add this $600 to it, plus whatever all these other labs that might be associated with that. And then the actual treatment when they refer you to a specialist. So that's going to be $600 plus this $100 plus whatever else. You can probably expect to be paying about $1,000 at least when it's all said and done. Whereas maybe you have an insurance plan that covers $3,000 of this $3,500, in which case you only have to pay $500 for this MRI, and then most of the specialist care is already covered. So you can start to see that one disadvantage to all of this is that you still need an insurance plan. You're still going to have to see a specialist, probably, maybe at some point. And so you're going to have to pay this $500 per person per month on top of this extra $100 per month to get these contracted prices. So advantages are it's preventative. It promotes preventative care because you've got consistent access to your doctor. And then competition promotes high quality and low cost. Basically, if there's two DPC physicians, they're going to have to compete with each other for the best quality at the lowest cost because their prices are very transparent. And then it's also a better reflection of the market prices. So, you know, if these people can make a good income off of 90% off lab contracts and everything included in $100 per month subscription fee, then obviously the price of healthcare doesn't have to be as much as it appears to be, as much as it currently is. So as far as a cost reduction strategy, I think this is pretty remarkable. But it does have disadvantages. We already have a lack of primary care physicians. And so the fact that, I mean, if we really took this and developed it into like a nationwide kind of system, um, we'd need over double the amount of primary care physicians we currently have to cover just the amount of patients that are covered by a primary care physician already. We'd need even more than double to cover everybody who really needs a primary care physician. So basically limiting yourself to 500 or 600 patients instead of 1,000 to 1,200 would mean we need to have more primary care physicians. Fortunately, most of the people, if you look up direct primary care, they really enjoy their jobs. They report less burnout. They feel like they get to spend a lot of time with their patients and really get to be a meaningful relationship with them. So, so there are pros, and maybe that would attract some more primary care physicians. But by and large, I think that's a major disadvantage of this system. And then you'd still need a high deductible, high insurance or high deductible health plan. So basically, this would work really well for people who are by and large mostly healthy. It would not work well for people who are low income and already can't afford insurance. So if you need to afford insurance, you're probably going to spend your money on insurance, not on this direct primary care thing. So again, the people who need healthcare the most are probably the people who financially cannot afford it. And so adding an extra, if insurance is a necessity, then adding an extra $100 per month is not going to help people who already can't afford healthcare. And then finally, you can't pay for this with Medicare or an HSA. So they're actually politically pushing for this to change. Right now, direct primary care is, I think it's like legally defined as a insurance plan. That's what the IRA considers it. And they're arguing that they're not an insurance plan. So the monthly payment is not a premium, it's a subscription. So they're arguing that there is a difference because if you'll remember in part two, we talked about how HSAs cannot pay towards the premium. They can only pay towards deductibles. And so if they're no longer legally defined as a health insurance plan, then people could start to use their HSAs to pay for direct primary care, which would be a huge benefit to them. And I think that would promote some expansion. So direct primary care is a good option for people who are already healthy, who make at least a middle-class income. And it does put back into the market some more reasonable prices. So if everything was only 10% of what it is now, I mean, that'd be pretty crazy. So moving on to indigent clinics and NGOs. So NGOs are non-governmental organizations, and I don't have a lot of time to talk about them, but basically you've probably heard of a lot of them like Samaritan's Purse, World Vision, Doctors Without Borders, and Mercy Ships. So NGOs, a lot of them started in America, but they're actually made to be international. So a lot of people will donate to them and stuff like that, but almost all of these, I think Samaritan's Purse probably does the most local or national stuff. Everything else is a little bit more internationally focused. So that's a lot of money from America going out to help other countries, which is great, but it's not going to really solve the problems in America. So I think these are super cool. I'd love to get the chance to volunteer with one of them one day, but they're not really a sustainable solution for the entire country of America, although hopefully they'll do some good in other places as well. Indigent clinics, however, are a little bit more, actually they're a lot more locally focused. So indigent basically just means we're doing this for patients who don't have insurance. And Medical Care Mission actually changed their rules. I think I might be wrong, to where they accept people with that minimum coverage that the ACA allows, because the minimum coverage doesn't actually cover any treatment; it only covers testing. So so some of these clinics are allowing certain insurance plans that are otherwise unsuitable. So the Medical Care Mission, Dr. Eames volunteers with them, and she helped me get in contact with one of their accountants, and we had a long, like it was like an hour conversation, and I did not write anything down. So I came away after that and wrote down as much as I could remember. And I definitely can't translate all of that to you. She had a ton of cool stories about how God has provided for them, and how they've been able to help so many people in the community. And so these numbers that I'm going to run through are not going to do them justice, but they're very impressive. So the first number I want to throw out, though, is that they do provide about $6 million worth of services on a $1 million budget. So that's incredible. You're turning $1 million into $6 million. That's awesome. Now they do that because they receive donations. They receive donations, and then they receive not just financial donations, but also like pharmaceutical donations and stuff like that. And so one of their donors, who is actually not their primary donor. Their primary donor is individual people who just regularly give, up to $15, $25 a month. A lot of people do give more, but I think it's pretty cool that most of their money comes from individual people, not from these big corporate businesses. So I hope that encourages you when you're out of college and out of debt to be a just faithful, small amounts per month kind of giver. That really convicted me. So, however, they also get money from corporate places and from Hendrick. So why does Hendrick ER benefit from medical care mission? Well, if you'll remember from part one about the EMTALA Act, so Reagan signed this EMTALA thing into law, which basically made ERs free clinics. Well, then ERs were flooded with people who can't pay for their health care. And then there's so much paperwork and all of that goes into someone visiting the ER, because the ER is kind of built within the greater hospital system. So the rest of the hospital needs to compensate for what happens in the ER. And it's all super complicated to the point where it basically costs $2,000 minimum for a person to walk into the ER, be quote unquote stabilized, whatever that entails, even if it entails the most minimal care possible, and then for them to walk out. And usually when that happens, they don't pay for anything. So $2,000 per visit in an ER versus $150 per visit in medical care mission. So that same person decides, no, I'm not going to go to the ER. I'm going to go to medical care mission, and they're going to pay maybe $30. Medical care mission does charge a small fee just so patients have a little bit of skin in the game, which promotes some compliance. But overall, it's still pretty cheap. And that only costs medical care mission about $150 per patient, whereas it costs Hendrick ER $2,000 per patient. So the ER benefits by saying like, hey, we're gonna take you in and stabilize you, but have you heard of medical care mission? They might be able to help you in the future. So I think that's pretty cool. And then patient needs. They had a social working student volunteering with them for a while. And basically the student decided to do a capstone or some kind of project for her major on what the needs of these patients are. And out of housing, jobs, and then dental, vision, and medical care, she had them rank primary to least what they needed. And basically she found that they needed medical care more than anything else. But number two was actually surprising. They needed vision care. So a lot of people don't really think of vision care as being super duper important, but out of housing, jobs, and dental care, vision was more important than all of those to these patients who can't afford insurance. So that was something to keep in mind. Vision is super important to the people who don't have it. But then to us who do have it, it's usually can be taken for granted. So vision care is a huge missional need. Also dental care. Unfortunately, they no longer are able to provide dental care, but they did provide that for a time, and that was also a huge need. So there's another place called Heal the City in Amarillo, which is very different from Medical Mission, but it's also one of these indigent clinics. So they're actually free. I don't think they make patients pay for most of their services. They might pay for a couple services, but basically they provide acute care, chronic care, vision care, dental care, labs, and they have a pharmacy. So they do a whole lot. They were actually donated an old YMCA as their building. So now they're trying to come up with creative ways to fill that large building to benefit the health of the community. And it's not just for uninsured patients. So even insured patients can participate in some of the activities. So for their chronic care, they provide a lot of education on dieting, on diabetes, on how to create a workout plan. And so this is kind of stuff that benefits uninsured people as well. The drawback is that both of these clinics, and really all indigent clinics, take advantage of unique assets of the cities that they serve. So basically, Medical Care Mission benefits from Hardin-Simmons PA program and PT program and ACU's counseling program and a couple of other things that are very unique to Abilene. So Amarillo, it has Texas. No, that's Lubbock. So my bad. Amarillo doesn't have many big colleges, so they can't do that exact same thing. But on the other hand, Medical Care Mission wasn't donated a old YMCA building. So you can just see how each community has their different assets, and these indigent clinics will take advantage of those assets and turn them into a way to uniquely serve the people in their community. So advantages are they're innovative, they're super creative, and that allows them to fill the gaps in whatever kind of system that they're in. Where there are smart people who are good with money and have a heart for others, they're going to find ways to serve the people who are not benefiting from whatever governmental or societal system is in place. And I think that's pretty awesome because there will always be these gaps in whatever kind of systems we put in place. And so I'm grateful, and I think it's really cool when these people can fill those gaps. And then sometimes their services surpass traditional services because, again, these are creative people who are smart and who are good with money and who have a passion for helping people. So sometimes they provide even better care than people who maybe are smart but a little bit greedier or just not very good managers or something like that. So these are very talented people providing some good stuff. Disadvantages is they rely on donations. So that's just not a universal solution. Nothing that relies on donations can help absolutely everybody, but they can do some real good for a few people. And then they're not reproducible. So they're going to take advantage of the assets in each unique community. And they really rely on the uniqueness of each community in order to serve each community, which I think is a really cool, sustainable model. If you get to go on a mission trip with Dr. Eames, you'll probably read When Helping Hurts or Helping Without Hurting. And basically, they talk about some of the psychological stuff that goes with going on mission, preventing yourself from having this superiority complex. But also, they talk about some of the ways that you can contribute to sustainable missions. And one of them is this model called asset-based community development. It's basically exactly this. It's taking assets in each community to benefit the community, which allows the community to have some ownership. So that's really cool. So in conclusion, we'll give a little summary, reflection, and final thought. So brief run by each of these things that we've talked about today. The ACA succeeded in reducing uninsured by 50% in America, but not really in cutting costs. The conservative health plan focused on freedom and promoting small businesses, but it did not make any drastic changes, and it failed to offer a strong alternative to the ACA. And then public health shows some promise in cutting costs and in preventing non-communicable diseases. So it can potentially be that fence in our cliff analogy. Direct primary care also shows promise in returning the market to reasonable prices, but it could be a financial burden for the people who really need the most access to healthcare, because people are still going to need to purchase insurance with their direct primary care plan if they choose to do that. And then indigent clinics and NGOs. These are not universal solutions, but they're great at creatively filling the gaps that will inevitably be present in imperfect systems. So, in reflection, which of these potential solutions or trends is most fascinating to you and why? Are there any other movements or solutions that you would have added to this presentation? You probably know a lot of things that I don't. So what would you have added to this presentation? And then think about the questions we asked in part 1. Is it possible for an intervention to solve one problem without creating another? And then last is healthcare a right or a privilege? We talked about this a little bit in part 1, and I introduced the idea that maybe these aren't the best adjectives for healthcare. So are these adequate words to categorize healthcare? And that's what I want to do my final thought on. So we have talked a lot about healthcare. And we've talked about finances, we've talked about ethics, we've talked about politics, um, and a lot of details, a lot of statistics. The topic of rights and privileges hasn't really come up. We've been able to have hopefully an enjoyable, good conversation. It's not really been a conversation, but I've presented some information that I hope is good quality on healthcare, and we haven't really talked about rights and privileges. We have talked about needs, and we've talked about services. So in my opinion, these are two much better words to describe healthcare than right and privilege. There is a place for right and privilege, and you may have to draw the line and take a side on that. But ultimately, I think those are more polarizing than anything else. And I think that's another huge problem in our country is we don't agree on a lot of things. And I think part of that is because we're polarized over questions that don't really make a whole lot of sense or hit the right point. So right versus privilege is, in my opinion, not really the primary issue with healthcare. I think if we can shift the conversation to talking about how to actually provide for people's needs and how to make it a sustainable service, we're going to get a lot farther than if we argue about these kind of philosophical terms over there. So that's just my final thought. I'm a huge fan of finding creative ways to change the conversation in a way that's a little bit more practical and a lot less polarizing. So thank you for listening to all three of these presentations. I hope you enjoyed them. I know some of the information is a little bit dull, but hopefully it's given you a little bit of a better, bigger picture of healthcare in America. And so thank you for listening and hope you enjoy the rest of your class. Here are my references and the visuals.